Thank you very much for attending this presentation. My name is Gianpaolo Pirovano and I am the Medical Director of the MRI product line within the Global Medical and Regulatory Affairs of Bracco. The focus of my presentation will be the risk-benefit of gadolinium-based contrast agents in the year 2020, based on all the information available so far. I will refer to gadolinium-based contrast agents as GBCAs across my entire presentation. While the efficacy of GBCAs, which is dependent on their relaxivity, is well known and does not require any further explanation, their safety has been under intense investigation, specifically due to the new information about their biodistribution. On June 28, 1988, FDA approved the first GBCA for clinical use in MRI. With that announcement, the MRI industry was irreversibly transformed. As of today, there are 6 GBCA available on the US market. There were 9 as of 2018. One important question is, are all these agents the same? From this table, you can see some of the major differences. 4 different classes of GBCAs are commonly applied in clinical practice: linear and macrocyclic GBCAs based on the ligand structure, and ionic and non-ionic based on their net molecular charge. Omniscan and Optimark are linear non-ionic, Multians, Magnevist, Eovist, and Ablavar are linear ionic, Proance and Gadavist are macrocyclic non-ionic, and Dotarem is macrocyclic ionic. Optimark and Ablavar are no longer available on any market in the world, while Magnevist has been withdrawn from the US market only. Most agents are extracellular specific contrast, with rapid distribution to the extracellular fluid space and elimination by the kidney. The first approved agent was the linear ionic Magnevist in 1988, and the last was the macrocyclic ionic Dotarem in 2013. You can see from the chemical formulas displayed in the slides that GBCAs differ not only for the linear and macrocyclic or globally charged or neutral structure, but for the number and type of lateral groups that provide different extent of key physicochemical properties to individual molecules such as relaxivity, protein binding, and hepatospecificity. In recent years, there has been a renewed interest in some physicochemical properties of gadolinium chelates, like relaxivity that relates to efficacy and stability that relates to gadolinium retention. The strength of the bond between the gadolinium ion and its chelating ligand molecule differs among the various approved GBCAs, with the macrocyclic showing better kinetic stability than linears and therefore much longer dissociation half-life. Benefit risk assessment is the foundation for FDA regulatory review of human drugs and biologics. Simply put, for a drug to be approved for marketing, FDA must determine that the drug is effective and that its expected benefits outweigh its potential risk to patients. Benefit risk assessment is basically an evaluation of 2 dimensions. The dimension of benefits is measured primarily in terms of efficacy, namely the successful diagnosis for contrast agent of the condition for which the drug is indicated. The dimension of risks include the safety profile observed in the form of sum of all experienced adverse drug reaction or ADR, but also includes the potential risk of unobserved ADR anticipated on the basis of the mechanism of action. Let's specifically look at some of the key factors determining the benefit risk of GBCAs through a number of key questions and answers belonging to the risk assessment of GBCAs. The first question reads, what is the weight of the evidence that supports that the risk exists? Well, like all other pharmaceuticals, GBCAs are not completely devoid of risk. Small but still real risk, based on over 30 years of use in clinical practice. There are known risks for acute adverse drug reaction and NSF, while the risk for gadolinium retention is still unknown. Further question is, how often is that the risk will occur? Well, although it is clear that certain patients are at increased risk of experiencing an adverse event to all intravascular contrast media, including GBCAs, contrast reactions remain sporadic and unpredictable. For gadolinium retention, the risk is unknown, but it would be related to every injection. For NSF, the risk is dependent on individual GBCAs. Another important question is the risk preventable? The definitive answer is no across the board. It is definitely no for acute adverse drug reaction, as by definition they are sporadic and unpredictable. The answer stays no for NSF, the risk can be minimized for NSF, but not eliminated. In fact, there are still cases of NSF that were reported after unique use of macrocyclic GBCAs, though very, very few. The answer is still no for gadolinium retention because, as I said before, the risk is unknown. The last question under consideration is, does the risk outweigh the benefit? And the answer is simple, no, whenever the GBCA is indicated. Let's start discussing the acute adverse events to GBCAs. It is important to keep in mind, as previously said, that GBCAs are by definition drugs. This means that they produce the intended effects based on the law of physics, but may also produce unintended untoward effects. One key question that it is still unanswered due to the lack of solid data is any agent safer than the others? Here are some facts. All contrast agents may cause adverse events, and this is undisputable. All GBCAs available on the market have caused adverse events. You can simply read their package inserts. All commercially available GBCAs have comparable adverse reaction profiles, including mild reaction, such as nausea and vomiting, and severe hypersensitivity reaction, as reported in the literature and very importantly confirmed by all regulatory authorities around the world without any distinction. The most reliable source of adverse event data is from prospective development studies. Unfortunately, most of them are non-comparative and their size is too small to allow robust and unequivocal conclusion on GBCA comparability. Irrespective of any methodological flaw, these data have been published claiming to show differences in adverse events across various GBCAs, but they were all retrospective surveys or observational studies with serious selection biases, Weber effect, Lally effect, and outright errors. What would be then the best way to reach a solid and disputable conclusion on this subject? The answer is prospective randomized blinded controlled trials that sit on top of the evidence-based medicine pyramid. These studies represent the most rigorous method for testing cause-effect relationship and contain an unbiased distribution of confounders. Unfortunately, these kind of studies are very expensive and time-consuming, and this is the reason why they are so uncommon. Actually, they do not exist in the peer-reviewed literature that is instead filled by retrospective database analysis and observational studies that are fundamentally flawed despite their significant use for commercial reasons. This table shows you the reason why prospective randomized controlled blinded clinical trials comparing two or more GBCAs have never been performed. Considering the general low rate of AEs and the potential minuscule differences between different agents, you would need millions of patients to create a statistically powered, robust answer to the question about potential differences between GBCAs in terms of safety. Based on statistical calculation established in the assumption you can see in the slide, you would need almost 1 million to about 6 million patients to compare two agents, and this applies just to two agents. You can see in the table rates of adverse events from different GBCA prospective observational studies. First of all, pay attention to the different size of the studies, ranging from 20,000 to over 100,000. The only allowed conclusion from this data is that all GBCAs are safe as far as acute safety is concerned, with low rates of AEs across all agents. The same can be stated when we look at all retrospective studies. All agents look pretty safe to me. Can I say anything about differences between them? As an experienced researcher, I do not think I would be allowed to claim one agent safer than the other based on this data. However, commercial organizations have used such data to promote individual agents as better than others. To conclude on acute adverse events from GBCAs, individual experience or word of mouth may lead radiologists to think that there is a difference in the safety of GBCAs. Well, the science does not agree with this statement. More importantly, regulatory authorities worldwide, including FDA, European Medicines Agency, and many others who read through the available evidence, as of today concluded that no differential safety labeling is warranted in the prescribing information of GBCAs. Second, but not less important, no wording for differential safety profile of GBCAs has ever been issued in guidelines from professional societies, including the American College of Radiology, the ASHNR, and the Canadian Association of Radiology, and others. All GBCAs were considered very safe, even safer than iodinated contrast agents since the late 80s. Unfortunately, two possibly linked tsunamis hit radiology, more precisely nephrogenic systemic fibrosis in 2006, when Grobner published the first cases of NSF associated with the administration of Omniscan, and gadolinium retention in 2014, when Kanda published the connection between abnormal T1 shortening in the globus pallidus and the dentate nucleus and gadolinium retention in the brain in patients who had undergone repeated prior administration of Magnevist and Omniscan. Let's start briefly talking about tsunami number 1, nephrogenic systemic fibrosis. Even though the first cases of NSF were identified in 1997 and the first published report of 15 cases appeared in Lancet 2000, NSF has received a great deal of attention only in 2006 because of its possible association with exposure to GBCAs, commonly and widely used in MRI from the late 80s. While initially the most prominent and visible effects were observed in the skin, autopsy case reports in individual NSF patients described variable degrees of myocardial, pericardial, and pleural fibrosis, along with the involvement of nerves and skeletal muscles. NSF has been observed only in patients with either acute or chronic severe renal insufficiency with GFR less than 30 ml per minute, but mostly in patients with end-stage renal disease undergoing dialysis. Although exposure to gadolinium has been considered a possible trigger for NSF, a definitive cause and effect relationship cannot be made with certainty. NSF cases occurring after the sole administration of one GBCA are defined as single agent or unconfounded. If a case of NSF follows the administration of two or more agents, the case is reported as confounded. The association of the development of the disorder with an individual GBCA can be determined only on the basis of confirmed, unconfounded NSF cases. Using the total number of patients exposed to GBCAs as denominator, this condition would be extraordinarily rare. However, the incidence of NSF in the population at risk, namely those subjects with markedly reduced renal function, is substantially higher, and has been reported to be up to 13% and 18% in patients with end-stage renal disease and previous known exposure to Magnevist and Omniscan. Due to the limitation of spontaneous reporting, including possibility of underreporting and missing or of inconclusive information, data from clinical studies may be more relevant to understand a possible association between NSF and individual GBCAs. Almost all of the unconfounded confirmed NSF cases reported so far occurred after single or repeated exposure to three GBCAs, Magnevist, Optimat, and especially Omniscan. It must be borne in mind that the pathogenesis of NSF is still unknown. The hypothesis that free gadolinium is responsible for triggering NSF, according to the so-called stability theory or transmetallation theory, is far from being proven. The ASHNR Contrast Media Committee, the European Medicine Agency, and the US FDA all have classified gadolinium-based contrast agent into different groups based on reported association with NSF in vulnerable patients, although the scheme used is not exactly identical. The American College of Radiology came up with the classification of agents based on three classes. Group 1 includes agents associated with the highest number of NSF cases that have been contraindicated by authorities around the world in patients with severe renal impairment. Group 2 includes the 4 agents with few, if any, cases of NSF. This class includes the 3 macrocyclics and multians. Group 3 includes 2 agents, one is no longer on the market, Ablavar, for which there is insufficient data to determine the risk of NSF despite an alternative excretion pathway for Eovist. 3 recent pooled analyses about the risk of NSF have been published in 2019 and 2020. The analysis by Wallen, published in JAMA in 2019, assessed the risk of NSF just for ACR class 2 GBCAs, Multians, Proans, Dotarem, and Gadavist, in patients with chronic kidney disease class 4 and 5. Pooled incidence of NSF was 0 of 4,931. Upper bound of 95% confidence interval varied between GBCA due to different size of exposure, determining Multians to have the lowest upper bound at 0.12% with 0 out of 3,167 cases. The analysis by Luniera, which used a very rigorous methodology and was published in Annals of Internal Medicine in 2020, showed that the occurrence of NSF after exposure to ACR class 2 and class 3 agents was very rare. In patients with end-stage renal disease, 9 NSF cases developed in 348 patients with exposure to ACR group 1 agents, and no cases developed in 1,079 patients with exposure to ACR group 2 agent. Finally, Attari and colleagues examined clinical features and risk factors of confirmed NSF cases in their paper published in Radiology in August 2019. The authors found an NSF rate of 1.52 cases per million exposures for ACR group 1 agents and 0.008 cases per million for ACR group 2 agents. Also, they found that only 7 out of 639 NSF cases were reported after 2008, indicating that regulatory action and practice changes were effective preventive measures. The most widely accepted belief is that risk of NSF is lower with macrocyclic compound. Well, this is not entirely supported by the scientific evidence. In fact, Multians has always been assigned to ACR group 2 agent since the beginning, despite it is a linear ionic agent. Not only this, if you look at the peer-reviewed literature, Multians has had by far the largest exposure of the population at higher risk, with no cases reported. Using sales number to calculate the risk of NSF is totally inappropriate, because you must remember that the NSF risk is related only to patients with severe renal impairment and not to the whole exposed population, and it is proportionally higher, more severe the renal impairment is. You see here a number of papers in which Multians was exposed to very many patients at risk, with a total of almost 2,000 subjects with end-stage renal disease undergoing dialysis. And these are not even all the papers. These data confirm that Multians is one of the safest agents in renal impaired patients despite its linear structure. I want to conclude the NSF section of my presentation with a discussion of an apparent unconfounded case of NSF after exposure to Multians that has been published in an online journal in 2017, and you might have seen shown around at various meetings without any comment at all. Well, the case relates to a 57-year-old female with hypertension, chronic pancreatitis, malnutrition, chronic diarrhea, vomiting, hypoalbuminemia, and significant weight loss, who had an abdominal MRI with Multians to rule out pancreatic cancer. Her calculated GFR at the time of the MRI was 64 milliliters per minute. After 2 months, she was seen at the clinic with worsening of lower extremity swelling, severe burning pain, and leathery skin with loss of hair and severe reduction of ankle motion. Deep skin biopsy from the left dorsal foot revealed histological features possibly consistent with NSF. Despite multiple repeated efforts to reach out to the authors and offers to facilitate a full investigation of the evidence involving experts in NSF, the authors refused to respond. Aside from the refusal to cooperate, 3 notable anomalies are to be pointed out in this case. First, according to the clinical pathological criteria by Girardi, any cases defined as consistent with or diagnostic of NSF without a known history of renal dysfunction should be further evaluated by a consultant with extensive experience in NSF. The renal history of this patient was at least very equivocal. Second, Fibrotic changes were only noted in the patient's lower leg, where she suffered from chronic edema for a long time. The S in NSF stands for systemic. Fibrotic changes found only in the skin of the lower leg in a chronically ill and edematous patient living on the street do not constitute a systemic fibrotic condition. Third, a major differential diagnosis to account for in a patient like this is lipodermatosclerosis, which is a complication of venous stasis. It is a very painful induration of the distal lower extremities, occurring very commonly in patients who have edema for a great variety of reasons, including venous insufficiency. It is more common in women and is associated with immobility. In conclusion, this case is still considered to be medically unconfirmed due to the presence of very relevant anomalous features in the reported case, especially the lack of matching with clinical pathological criteria by Girardi. Pay always attention to details when you read or you are exposed to case reports like this, as they may lack substantial information to make a full and reliable assessment. Let's focus now on gadolinium retention. The evidence of gadolinium-related brain tissue hyperintensities on T1 weighted images of deep brain nuclei has raised concern on the clinical safety of GBCAs and in particular on the risk of neurotoxicity. Currently, gadolinium retention is at the forefront of attention because it occurs to any subject receiving an injection of any GBCA and has led to different regulatory approaches to GBCA management around the world, including restriction, educational programs, and notices and warnings. As displayed in the histogram, the interest on gadolinium retention increased for 2014, year of discovery, reaching a peak in 2018, and it is now gradually decreasing, even though numbers for 2010 and 20 are just relative to the first half of the year only. This temporal profile mirrors the similar trend that occurred for NSF in the first 3-4 years after 2006. The majority of manuscripts are review papers and studies investigating T1 hyperintensity of deep nuclei. Of the review paper, many frequently contain inaccurate information and several speculative statements not supported by evidence. Certainly, autopsy studies or clinical studies investigating potential neurotoxic effect of GBCAs are much more complex and demanding. A final observation is that the number of animal studies is also approaching 50, and the vast majority of these studies have been performed by companies involved with the development and sales of GBCAs. The eye-opener for gadolinium retention was the study published by Kanda and colleagues in 2014 that hypothesized the existence of intracranial gadolinium retention based on the observation of progressive T1 signal intensity increase in the dentate nucleus and globus pallidus at clinical MRI in human subjects who received repeated injection of Magnevist or Omniscar. Subsequent studies have enabled independent confirmation of progressive T1 shortening after administration of linear GBCAs. However, the scientific literature provided some evidence for the presence of this signal increases after administration of the macrocyclic Dotarem and Gadavist, despite most manuscripts have not shown dose-dependent changes in T1 signal after macrocyclic GBCA exposure. The reason for these dissimilar findings are unclear, and they may be related to differences in MRI examination and assessment parameters, heterogeneity in patient factor, and inaccuracies in patient data collection. In addition, it is unclear what gadolinium-containing species is producing T1 shortening, leading to the possibility that only the MRI visible form are being selectively detected at imaging. There are much more reliable ways to measure gadolinium retention using very sensitive assays, such as inductively coupled mass spectrometry or ICP-MS. Although macrocyclic show little to no T1 shortening even after many repeated administrations, not a single autopsy study using ICP-MS has failed proving that gadolinium retention in the brain still occurs even after a single injection of a microcyclic GBCA. Furthermore, few studies show T1 hyperintensity after less than 10 injections of Dotarem and Gadavist, as you can see in the displayed images. So far, quantifiable or visible signal intensity increases have never been reported in the brains of humans following multiple doses of PROANS. Before discussing the available quantitative data about retention, let's focus on one of the most interesting and still unexplained aspects of this phenomenon, namely its mechanism. The animal study performed by Jost and colleagues using 6 GBCAs approved for use in imaging of the CNS, both linear and macrocyclics, showed that GBCA penetrate from blood into the CSF in a very similar amounts independently of their chemical structure or physicochemical property. Dynamic flare MRI demonstrated a kinetic from the inner CSF spaces to the subarachnoid space and suggest a passive distribution and washout driven by convection and CSF flow. 24 hours after injection, GBCA clearance from the CSF was almost complete, whereas slightly higher gadolinium concentration were found in the cerebellum and pons, suggesting delayed excretion from these structures. The mechanism of final distribution from the CSF into the brain could not be evaluated in this experiment. However, it posed the basis for suspecting a role of the lymphatic system. It was clear from the study that the process of retention is dynamic and not static. The question that still remains unanswered is, does the gadolinium journey end at a certain point with complete elimination, and when? After days, months, or years? The temporal evolution and dynamicity of the gadolinium biodistribution process through the brain has been demonstrated in a total of 4 animal studies. Results were not always quantitatively consistent, and all studies were performed by different pharmaceutical companies. The older study by Smith at GE demonstrated an approximately 50% decrease of Omniscan 20 weeks after dosing. The plot confirms that gadolinium level measured in the brain with ICP-MS were dose-dependent and decreased with time. The study by Streminska from Gervais proved that a single injection of a clinically relevant dose of 3 GBCAs, including Omniscan, Multians, and Dotarem, resulted in a significantly higher cerebellar concentration of gadolinium after administration of the least stable Omniscan at 1 and 5 months than those observed for Multians and Dotarem, proving that not all linear GBCAs are the same. However, at 5 months time point, the gadolinium concentration in Dotarem group was also significantly lower than the gadolinium concentration in the Multians group, proving that the clearance is more effective for macrocyclic. The study by Jost and colleagues at Bayer was performed using Omniscan, Magnevist, Multians, PROANS, Dotarem, and Gadavist, with an observation time of 52 weeks. Animals injected with linear agent were found to retain much more gadolinium than those injected with macrocyclics. For microcyclic GBCA, the cerebellar gadolinium concentrations decreased significantly between week 5 and 52. Of note, while similar gadolinium concentration were found at 26 and 52 weeks for the macrocyclic GBCAs, concentration in the cerebellum at week 5 after PROANS was roughly 3 times lower than for Gadavist and Dotarem, as highlighted in a letter to the editor by Jaime and colleagues. These data agree with 3 other studies reporting lower concentration in brain and body tissues after PROANS administration than after administration of the 2 other macrocyclic GBCAs that I will discuss later. All these data indicate a possible faster clearance of PROANS that does not have an explanation so far, but has been noticed in multiple animal experiments at different time points and may have some clinical importance, considering that 5 weeks in a rat correspond to roughly 3 years for humans. One more study by Robert and colleagues proved that after the last injection of Omniscan, 75% of the total gadolinium was retained in the cerebellum at 1 year, while Dotarem showed a much more significant, rapid, and time-dependent washout. After this series of animal data, let's see what we learn from studies in human about the possible mechanism of gadolinium retention. 2 studies have been performed in human proving that gadolinium can be found in the CSF after intravenous injection of macrocyclic GBCAs, even in subjects with presumably normal blood-brain barrier. The first cohort prospective observational study done at Mayo Clinic quantified gadolinium in CSF samples by using ICP-MS from 68 patients who underwent Gadovist injection followed by lumbar puncture. The time between Gadovist exposure and CSF collection ranged from 1 hour to 25 days. Gadolinium was detected in the CSF of all 68 patients exposed to Gadovist, with a wide range from 0.2 to 1,400 nanogram per ml, regardless of age or CSF protein level. As expected, gadolinium concentration decreased with time. In the second study performed in Switzerland, CSF samples from 57 patients who underwent 1 contrast-enhanced MRI with Dotarim within 60 days of CSF extraction were analyzed using ICP-MS. Higher concentrations were detected within the first 8 hours after Dotarim administration, with a mean concentration of 1,100 nanogram per ml. Concentration were lower between 8 and 48 hours, with concentration at 870 nanogram per ml. After 48 hours, gadolinium was almost completely cleared from the CSF, with a residual 120 nanogram per ml, confirming its decrease over time. Although the exact mechanism of GBCA flux through the CSF remain poorly understood at this time, it is likely that choroid plexus, the site of CSF production through ultrafiltration of the blood, arachnoid granulation, the sites of CSF reabsorption, and the glymphatic system all play a role in both CSF and central nervous system biodistribution of gadolinium. The glymphatic system has been defined as brain-wide paravascular pathway for CSF and interstitial fluid exchange that facilitate efficient clearance of solutes and waste from the brain. CSF enters the brain along para-arterial channels to exchange with interstitial fluid, which in turn is cleared from the brain through convective bulk flow along the perivascular spaces around venous drainage system and ultimately ending in the cervical lymph nodes. Can this path be proven? Well, imaging data published in most part by Japanese authors prove that the time course of GBCA in the brain could be evaluated by 3D FLAIR imaging. The signal intensity increased significantly in the CSF and in the perivascular spaces at 4 hours after intravenous injection of Omniscan and PROAX. Several studies have been performed both in animals and humans to study this process, and the findings confirm the potential role of the glymphatic system in the clearance of gadolinium from the brain. The clearance of gadolinium from the brain appears to be faster for macrocyclic, possibly due to differences in the species of gadolinium retained between macrocyclics and linear. However, it may not be the same for all macrocyclic GBCA, especially in the early phases, as I'm going to show you in the next couple of slides. As reported in many publications, there is a strong trend to assume that all linear agents are similar to each other and should be treated as a single class, and that all macrocyclic agents should be treated as if their rates of gadolinium retention were effectively the same. Let's look at the available evidence by assessing studies quantifying gadolinium at different early time points up to 5 weeks after injection of macrocyclic GBCA using mass spectrometry in animals. All studies consistently demonstrated similar results. In all 3 studies, the level of gadolinium after PROANS in the brain are close to the threshold of detectability of the assay. 40% to 3 times less gadolinium was consistently detected in the brain of rats from 1 to 5 weeks after PROANS injection, compared to equivalent cumulative doses of the 2 other macrocyclic Dotarim and Gadovist. Since no differences have been found in the CSF gadolinium levels up to 24 hours after injection of either linear or macrocyclic GBCAs in the previously described study by Jost, the differences observed both in the cerebellum and cerebrum after macrocyclic GBCA exposure may be due to a more efficient clearance of PRO-ANS in early phases after injection. Of notice, the results obtained in the brain are consistent in kidney, liver, and skin. The only exception is bone, where lowest gadolinium values were determined for dotarem. It was surprising that about 6 to 8 times higher level of gadolinium were noted in kidneys after dotarem and Gadavist than after PRO-ANS at 28 days after the last GBCA exposure. Given the strikingly similar profile of the measured GBCA levels across all soft tissues organ, with PRO-ANS consistently returning lower level of retained gadolinium, it is likely the unique physicochemical properties of the gadoteridol molecule may be relevant not only in the brain but also across all soft tissues. Common to many animal studies on gadolinium retention is that the findings, although important, can only be considered as indicative rather than representative of the more complex biological situation in humans. Few studies have been published investigating the amount of gadolinium in human cerebral tissue. Only 2 studies produced comparative data between different GBCAs. The first one was the study by Murata and colleagues, who found that gadolinium is also retained with macrocyclic agent even after a single injection and up to years after the last injection. PRO-ANS normalized brain deposition levels measure lowest among the agents studied. However, it is not possible to draw any firm conclusion from this data about differences between agents, since only single case measurement for some agents were available. In the second study by Fingerat and colleagues, highest gadolinium concentration of more than 700 and 900 nanogram per gram of tissue could be detected in the dentate nucleus of 2 patients. The first patient, who, by the way, had NSF, received 5 injections of Omniscan and 2 injections of Gadavist between 10 and 11 years before death. And the second patient received only 1 injection of Omniscan, but just 1 day before death. While it is important to know whether gadolinium is retained in body tissues, it is even more important to understand in what chemical form is gadolinium retained. Because the physiological environment in which the GBCAs is present is chemical very diverse, a range of differential potential species can be expected. In fact, retained gadolinium chemical form may include the intact molecule, many possible inorganic soluble or matrixed entities such as hydroxyapatite or inorganic salts, including but not limited to phosphate and carbonates, because of colocalization of calcium and phosphorus in the same deposit in different experiments. And finally, gadolinium bound to macromolecular or macrostructural forms with a size larger than 250-300 kilodalton. In the study by Frenzel, gel permeation chromatography separation did not allow identification of the chemical nature of the macromolecule and whether it had bound the intact GBCA or the transmetallated gadolinium ion. However, it must be kept in mind that these macromolecular species have relaxivities which may generate a visible MRI signal enhancement at concentration as low as 0.5 to 1 micromole of gadolinium per liter. As of today, all the species are unknown. It is also unknown if and how the gadolinium species being present in vivo may appear and disappear in a highly dynamic fashion, as they are in rapid equilibrium with each other and the multitude of available free ligands that may change from one tissue compartment to another. The study by Gianolio and colleagues using ultra-performant liquid chromatography coupled with mass spectrometry confirmed that after intravenous administration of PRO-ANS, 100% of recovered gadolinium in the brain structure corresponded to intact gadoteridol. Conversely, for Omniscan, only up to 20% corresponded to intact gadodiamide, while the remaining accounted for about 50% of insoluble gadolinium species, possibly the same inorganic salt described before, and another 30% for the high molecular weight soluble species, namely gadolinium bound to macromolecules. So, why speciation is so important? Well, first of all, because it can inform us about potential toxicity of different species that might be different. Second, different species may be more efficiently cleared from different tissues. Third, depending on the nature of the species identified, we may gain clues about potential efficacy of chelating therapy. Unfortunately, speciation is a technically challenging analysis, particularly because it cannot be done on living tissue, and the manipulation of the tissues needed to perform some of these assays may alter the chemical environment of the retained gadolinium species, which in turn may affect the final results on the individual samples. Now we come to the most interesting part of the discussion on gadolinium retention for clinicians. Does gadolinium retention cause damages to tissues, and particularly brain cells? In 3 studies performed at Mayo Clinic, in both adult with and without brain disease and pediatric patients, no gross abnormality at structural neuropathology assessment could be demonstrated even after 29 injections of Omniscan, the GBCA known to be retained most in human brain. Similar findings were found by Fingerat in her study, showing that gadolinium deposition in the brain are restricted to blood vessel walls while the neuropil is spared, and apparent cellular reactions are absent. These results confirm the finding at least 4 neuropathological studies conducted in animals. The central clinical question in regard to gadolinium retention is whether retained gadolinium has a clinically meaningful effect. What do available data tell us in this regard? The current available data, mainly based on clinical retrospective studies involving large cohort of patients, like the large population-based study by Welk and colleagues, including almost 100,000 patients receiving at least 1 dose of GBCAs, that showed no significant increase of Parkinsonism compared with patients undergoing an enhanced MRI. Another still unpublished cohort study by Mayo Clinic, including over 4,000 patients, concluded that Omniscan exposure was not a predictor of excess cognitive decline or altered motor performance compared to controls. More recently, Vimazal reported a case series of 4 patients with glioblastoma multiforme exposed to at least 50 injections of gadolinium over a period of 13-14 years. When you focus your attention on the amount of gadolinium injected, you notice that from half a liter to almost a full liter of GBCAs was administered to this patient, with 52 to 71% of the injection being linear, and extensive use of multians that for 3 out of 4 patients accounted for more than 200 ml injected overall. Again, no neurological and neuropsychological impairments were related to MRI signs of gadolinium retention in the dentate nucleus and globus pallidus. Despite the amount of evidence available, the potential clinical consequences of gadolinium retention remain unknown. For this reason, FDA has mandated a post-marketing requirement prospective studies to all GBCA manufacturers. The study has been agreed upon by the 4 marketing authorization holders, namely Bayer, Bracco, GE, and Gerbe, and FDA, and is currently being initiated with the inclusion of centers around the world. The study has been named Odyssey and is going to last many years, considering the size, design, and the complex study requirements. The study will require about 2,000 participants in group of patients exposed to linears, to macrocyclists, and control never exposed to GBCAs. Patients in the 3 arms will need to be neurologically normal at enrollment and be likely to receive 5 injections of either linear or macrocyclic GBCA only in the exposed arms. Each study subject will undergo a battery of motor and cognitive tests once a year for 5 consecutive years. If you are interested to have more information on the study, it has been posted on clinicaltrial.gov in May 2020. Medicine is an art of balancing risk and benefit. When it was revealed that gadolinium in GBCAs was not fully excreted from the body, even in patients with normal renal function, it threw the risk-benefit assessment of patients being considered for contrast-enhanced MRI into turmoil. Historically considered extremely safe, GBCAs are commonly administered and necessary for the diagnosis of countless serious diseases. But now we unequivocally know that regardless of renal function and apparently regardless of patient status or type of contrast agent, if a GBCA is administered, a very small quantity of that gadolinium will remain in the patient for an indeterminate and possibly long period of time. There are several risks and benefits that must be considered when selecting which GBCA to use, with some pertaining to population of patients, some to the characteristics of the GBCAs, and other pertaining to the healthcare system in general. You can see them in the table from this interesting paper by Davenport. In light of these various factors, the decision-making involved when selecting an agent is complicated and difficult to reduce to a single issue. As I showed you, by using observational data to compare contrast reaction is complicated and subject to biases that cannot be avoided even using meta-analysis techniques. Therefore, similar to currently available data related to gadolinium retention, the reaction rates reported by individual studies are not the end of the story. All safety risk and efficacy benefit must be considered for this decision-making process. In spite of more than 30 years of use of GBCAs and almost 500 million doses administered with highly significant number of linear GBCA injections, important information about the biodistribution and tissue interaction of each GBCAs in clinical use remains unknown. Retained gadolinium levels depend on individual GBCAs, interval between administration, individual organs, and possibly cumulative dose. Although consistent in animal studies, differences among agents do require more data to be fully validated in humans. However, available evidence on the dynamic gadolinium retention process so far shows ProHance to have the lowest gadolinium retention in the early phases of GBCA clearance from the brain in animal studies. The form of retained gadolinium-containing species is still unknown, as well as how it may change over time in different tissues. So far, beyond NSF, gadolinium retention has not been associated to any damage to any involved tissues and any clinical adverse effect. All the unknowns, including mechanism, form, extent, and clinical implication, form the basis of the research roadmap to improve our understanding of gadolinium retention and its clinical importance. FDA is the only authority in the world which has asked to address the most relevant knowledge gaps, requiring marketing authorization holder of GBCA to perform specific animal and clinical studies. So as a final suggestion, trust the data, the evidence, and not the unsubstantiated opinion with commercial spins independently of where they come from. As Socrates said, smart people learn from everything and everyone, and average people only from their own experiences. In conclusion, GBCAs are indispensable adjunct to MR imaging in a broad spectrum of diseases for both detection and therapeutic guidance. Their accumulated safety record is still extraordinarily positive despite the unknowns related to gadolinium retention. The use of these agents has always been guided by risk and benefits, and new knowledge will inevitably affect both the numerator and denominator of this equation. However, as widely repeated and reported, one of the worst possible endings to this story would be for radiology to unnecessarily deprive patients of crucial, even life-saving medical data from gadolinium-enhanced MR imaging. Thank you very much for your attention.